Now for chapter 34, do not expect to come out here of this class thinking that you're competent to read cardiac monitors at work. All right, we are only doing the basic telemetry classes for techs is a 3-day class, and the one for RNs is 2 weeks. That's live, plus they have several weeks of homework before they can come to class. So we're just doing the basic enough for us to answer questions on the NCLEX, right? And for exam purposes, I'm only using the strips, causes, signs and symptoms, interventions, including drug therapy, especially drug therapy that's found on your textbook. For heart block, since this textbook did not discuss heart blocks, I will have to give you resources and I'll email them to you for exam purposes, okay? Because we do have graduates that say that they did receive questions about heart blocks on the NCLEX. All right, so that's the plan. Let's get started. So dysrhythmias is a electrical picture of the heart. By looking at the electrical conduction, which is represented by waves and complexes on an ECG strip or a cardiac monitor strip, is a visual representation or visual picture of what's going on inside the heart. To do that, let's understand first the normal cardiac electrical conduction pathway. So we have 3 pacemakers. The primary pacemaker is the SA node. Now, if you have difficulty understanding what a pacemaker is, let's review A&P real quick. So in A&P, you learned about action potential, that the heart has its own action potential. Unlike skeletal muscles that require nerve stimulation in order to feel and function, the heart doesn't require that. The heart cells generate their own electrical impulses, so therefore they do not require stimulation from the brain in order to function. They function independently. However, they can be influenced by several hormones, namely those coming from the sympathetic and parasympathetic systems. However, in order for them to function, they really do not need that. So they can function independently of the body, in fact. So every electrical impulse, when normal, should begin from the SA node. So the SA node is located at the right atrium, right at the entry, right at the door from the superior vena cava. So this is the primary pacemaker. It is capable of generating 60 to 100 beats a minute. So if you see on a ECG strip a P wave is representing atrial depolarization, meaning the atria, both atria, depolarized or contracted. The presence of a P wave indicates that contraction was stimulated or was initiated by the SA node. Therefore, if you see no P wave, there are 2 implications there. No P wave means you didn't have a very effective or a normal atrial contraction. And the second implication is that the impulse that generated that did not come from the SA node. So, and again, a P wave tells you 2 things, that the atria contracted, both atria contracted, and that the electrical impulse came from the SA node. That is the significance of seeing a P wave. So when you look at a ECG strip, the first thing you always look at is, are there P waves? As I mentioned, there are three pacemakers. The secondary pacemaker is the AV node. There are two functions of the AV node. One is it has a very important job. It will, once it receives the electrical impulse from the SA node, it has to delay the transmission to the ventricles. So let's say this is your heart. This is the AV node right here. And this is your septum. The AV node is right here. And these are the third pacemakers, or the tertiary, which are the left and right bundle of His, and the bundle branches, and then the Purkinje fibers, which stimulate the ventricles. So this is the AV node. It has two jobs. One is to delay the impulse. Now you've seen lightning light up the sky and then hit something on the surface of the earth, right? Whether it's the ocean or somebody's house or a tree. Did it take long for that electrical, that bolt of lightning to come out of the sky and then hit something? Did it take a long time for that to occur?
No.
No. You saw it, and then next thing you know, it hit something. So same thing, the electrical impulse coming from the SA node instantaneously hits and travels and then reaches the AV node, correct? But the AV node, again, has a very crucial function. It should delay that transmission, because otherwise, once the electrical impulse is generated, then it will travel through interatrial branches, causing the atria to contract. But that same electrical impulse, once it reaches here, it will instantaneously go down here, resulting in a simultaneous atrial and ventricular contraction, which is disastrous, because if they both contract at the same time, then the blood coming from the SA node, as well as the blood leaving the ventricles, there will be no correct timing, because in the first place, the valves will be unable to open, because these guys will pump to open this, but if these two guys also pump at the same time to close it, then we'll have no cardiac output at all. So they'll be beating, but then there'll be no resulting cardiac output. So there has to be a delay. So once that signal reaches the AV node will hold on to it for about 0.12 to 0.2 seconds. So it will delay it. It receives it instantaneously, but then it will delay transmission down to the ventricles for between 0.12 to 0.2 seconds. And then it will delay it after between this time, and then the ventricles contract. So as long as this is occurring, then you'll have S1, S2 sounds, and then you have very good cardiac output. So that function of the AV node is very, very crucial. The other function of the AV node is once it, let's say there's an event, which is now your heart blocks. In heart blocks, there is one or several reasons wherein that electrical impulse coming from the SA node does not reach the AV node. We'll talk about them later during the second half of class, wherein it doesn't reach the AV node. Something blocked it along the way. So as a result, the AV node receives no electrical impulse from the SA node. What it does is generate its own. However, as you see here, the AV node is only able to generate less than unlike the SA node, wherein it's capable of generating 60 to 100, the AV node can only generate between 40 and 60. So the resulting ventricular rate, therefore, if the impulses are coming from the AV node, the patient will be bradycardic, which is the characteristic of heart blocks, especially a complete heart block. So your heart rate in a complete heart block is anywhere between 40 and 60. It never reaches even in the 50s. So you have a heart rate in the 40s, sometimes in the 30s. I'm referring to ventricular heart rate. Okay. Anyway, we'll get to those shortly. And then finally, the bundle of His, which are coming from the left and right bundle branches, are the third pacemakers. Although they are pacemakers, it's not worth talking about because the intrinsic rate that they can generate is only between 20 and 40. That's never going to be enough to sustain cardiac output. So don't even bother talking about them. Right, here is a representation of a typical cardiac cycle. So from the moment the SA node fires and then an electrical impulse and reaches the AV node delays it for a few moments and then transmits the same signal down to the left and right bundle branches and then allowing the ventricles to contract. That is one cardiac cycle. So when you see here a P, a QRS, and a T wave, that is one complete heartbeat. Okay, that is one cardiac cycle. So that's the entire time that it takes for blood to enter the atria, leave the heart, either to go to the brain or to go to the aorta. So that's one cardiac cycle. Any questions so far? All right, let's proceed. So as the same figure 34-1, so P wave here, as you can see, this bracket here tells you that the P wave, what's happening during a P wave? P wave is where both atria contract. And the PR interval, which is measured from the P to the beginning of a Q, before the Q begins, P to beginning of the Q, is the PR interval. Therefore, this is the delay that I was talking about earlier. So this pause, wherein the AV node does not transmit the impulse it received from the SA node, is the PR interval. It's not. It's crucial to allow ventricles to fill first before the QRS happens. The QRS, as stated here, is the ventricular contraction, or technical term is ventricular depolarization. Repolarization and depolarization are technical terms about the cell. So if you remember again in action potential in A&P, so this is a resting cell. A resting cell is no electrical activity is happening. It's all negatively charged. As it becomes more positively charged, little by little, calcium ions are getting into the cell. So this is now repolarization. So this is at rest. This is now early repolarization. And now once the cell is now overloaded with positively charged ions, then of course it has to discharge all that energy, causing depolarization. So this is again a resting cell wherein no electrical activity, nothing. This one is early. It's starting to repolarize. Then finally, when it reaches a state wherein it is full of energy, so it will depolarize or it will contract. Right? And then this goes over and over again, 60 to 100 times every minute. There are 4 characteristics of cardiac cells. At one point during conception, when we were, our parents hooked up, your dad said to your mom, "Sup?" And then your mom said, "Nothing." And then, something happened and then you were conceived. Okay. So now you went from one single cell to now double to 4, 16. And we know the rest of the story. You are now who you are. At one point during embryonic development, the heart was one single stem cell. As it started to differentiate, they possessed all of these 4 characteristics, meaning each cardiac cell had the pacing function. They were able to generate electrical impulses. All of them were excited by that electrical impulse. All of them can conduct that electrical impulse. And all of them had the ability to contract in response to that electrical impulse. However, as the heart developed, grew more and more, and then some became the myocardium, some became the pacemaker cells, some became the endocardium, etc. They started to lose some of the characteristics, mainly the automaticity, became more specialized in the 3 pacemaker cells: SA node, AB node, and the left and right bundle branches all the way to the Purkinje fibers. All of them, though, retain the excitability and conductivity. However, contractility is now specialized in the myocardial part of the heart. The actual muscle are the only ones that were capable of contracting. However, as we age is a #1 risk factor for dysrhythmias, along with some other causes which we'll discuss today. This causes other cells to generate impulses when they shouldn't be doing that. A perfect example is atrial fibrillation. So in atrial fibrillation, there are several cells in the atria that fire signals that they shouldn't be doing. Only the SA node should be generating the electrical impulse, but there are now some cells that become irritated and now begin firing or generating electrical impulses. But since they are not the SA node, they therefore do not generate the same electrical impulse coming from the SA node. That's why they will result in no P waves. Because remember I said P waves is the only normal electrical activity if the impulse came from the SA node. And there are several other causes, but again, the #1 risk factor is age. So as we age, we're talking about a 65-year-old heart now, a 80-year-old heart. So of course, part of wear and tear, deterioration, and if these occur below that age, then it's due to the certain substances or lifestyles that we do that interrupt these normal functions. The ECG paper is a series of vertical and horizontal axes. The inventor was Dr. Eindhoven. So this is that would have been, you talk about Dr. Eindhoven and the Eindhoven Triangle if you attended the class, but we don't have time for that. Let's begin with basic terms. Let's begin with the isoelectric line. In a typical ECG paper, I'll go back there shortly. Okay, you see here an ECG paper. So you see the horizontal as well as the vertical lines. If you look at this sample here, this ECG tracing here, the lines and complexes, as you notice, do not fall on a solid line. They seem to rise and fall at an imaginary straight line, if you notice. So for this example, the chart figure 34-4, the isoelectric line seems to be right below this solid line right here. So that's where you see the waves leave the isoelectric line and then return to the same isoelectric line. Right? So that is what we call the isoelectric line. What's the significance? Well, that is where you start measuring the each wave and complex. So you need to identify where is my isoelectric line. Okay? So it usually indicates that there is no current flow, meaning there is no electrical activity in that um, isoelectric line. Before I go any further, the horizontal lines are measured in seconds. Okay, time in seconds. Whereas the vertical axis on the ECG paper is going to be representing voltage. Okay, how much electrical activity is happening at that particular moment. Okay, again, the vertical axis is measuring electrical voltage, okay, electrical current. And then we have the horizontal, which is going to be measured in time in seconds. What's the difference between positive and negative deflection? It's really the direction of the wave or complex. If it's going up, of course, that's a positive deflection. If it's going down, then that's a negative deflection, right? Because it is measuring voltage. So therefore, any wave going above the isoelectric line is considered a positive deflection, whereas if it's below the isoelectric line, then of course that's a negative deflection. Lead systems. When we say 12 lead ECG, the word lead there has two meanings. When we say 12 leads, we are talking about a view. Okay, so it's a picture. So a 12 lead ECG gives you 12 views of the heart. Think of it as we put the heart on a pedestal, on a lectern, for instance, or on a table. And then you have 12 different photographers positioned at certain points, giving them different vantage points of the heart. So for instance, ABR, which is on the right shoulder, actually is looking at the heart from the left side. It's a long story, but that's what's going to happen. Because of the positive and negative leads found on each electrode, which is the second meaning of the lead, there are 12 leads in a 12 lead ECG, meaning giving you 12 views. However, there will only be 10 leads or 10 electrodes. So there are 4 limb leads because you have 4 limbs. You have one for the right arm, left leg, right leg. And there are 6 chest leads, 6 precordial leads. Now, why are there 6 views on 4 limbs? So this is what I'm trying to explain. So in the case of the AVR, for instance, the line of sight, because of the interaction of the negative and positive poles, it's actually looking at the heart from the left side, from the left shoulder going to the right shoulder. And that's just one example. Again, I don't have time to conduct the entire class, but that's an example why you would have one interaction between between limb leads results in more than one view. So that is why there are 6 views when the 4 limb leads interact. Okay, it has something to do with the Eindhoven Triangle. Maybe I can demonstrate shortly when we get to a 12 lead ECG. So there are again 6 chest leads. So we have V1, V2 up to V6. Okay. Now they are positioned. V1, V2 will be in the second intercostal between the second intercostal to the left sternal border, whereas the V2 will be on the right sternal border, and V3 will be around fourth intercostal space. Anyway, these are not testable, so I'm just right here. Okay, so this is the placement of your leads. So you have 6 chest leads, and then you have 4 limb leads. The limbs, depending on the model of your ECG, it can be placed on the wrist or they can be on the deltoid. Same thing here, they can be on the legs right here, or only on the limbs, on the lower legs. For continuous ECG monitoring, these are obviously less giving you less views because there will only be 5 electrodes placed on the patient. So for telemetry purposes, you've seen them probably if you remember in clinical, you went to a telemetry floor, you had patients who have a telemetry box, and you will find there are 5 leads attached to their chest. One in the sternum, and then one in each left and right upper chest, and then another in the left and right lower quadrants of the abdomen. So the interaction here will result in you having a total of 12 leads or 12 views. So the triangle so let's say this is Michael. So that's Michael. So the Eindhoven Triangle results in you having a lead 1, 2, 3, ABR, ABL, then LL left leg, or AF, AF, no, ABF, sorry. AB foot, and then this is only a ground lead. This one is ground. Okay, so you have AB foot or ABF. So these are your leads 1, 2, 3, ABR, ABL, ABF. So each of these gives you a different view of the heart. So Michael's heart is right here. Then plus you have the 6 chest leads, V1, V2, V3, V5, V5, 6. So think of it as the heart being viewed from different angles. Okay, this one looking at here, this one looking this way, this one looking down from the top, right? And then the 6, of course, are looking at the heart from the back. Again, this is not testable. I'm just trying to explain to you why there are 12 views using 10 electrodes. All right, let's go back to the significant parts. All right, so when you either get a 12-lead ECG or print from a telemonitor recording, you'll have the ECG paper. Again, the horizontal lines are representing time in seconds, or measures time in seconds, whereas your vertical axis is going to be measuring voltage. Sorry, I'm just checking attendance. Okay. You can still see the screen, right?
Yeah.
Okay. So here are the vertical and the horizontal lines. So you see voltage up here, and we have duration or time in seconds. So let's magnify one big block. So you see on the lines, the resulting, we have tiny blocks in there. So we have tiny squares, and then we have big squares. So here we magnified one big square. Each tiny square is measuring 0.04 seconds. Whereas that means if there are five small boxes in a horizontal line inside each big block, that means 0.04 times 5 equals 0.2 seconds. Therefore, you know that one big block is 0.2 seconds. So here's an example. To make things easy for you, whenever you print a strip so that you don't have to keep counting, the paper gives you 3-second markers. This is a 3-second marker, a 3-second marker, a 3-second marker. If you don't trust, well, how do I know that is 3 seconds? Okay, so if one small block is 0.04 seconds and one big block is 0.2 seconds, therefore, how many big blocks are there in 1 second?
5.
5. Okay, so we need 5 big blocks. 0.2 times 5 equals 1 second. So let's count. Let's see if this is really 3 seconds between this marker and this marker. Is this really 3 seconds? So let's count. 1, 2, 3, 4, 1 second. 1, 2, 3, 4, 2 seconds. 1, 2, 3, 4, 3 seconds. Make sense? All right, so on the test question also, I'll give you strips that have 3-second markers, but maybe if there's a strip without a 3-second marker, then you know how to create one. All right, so you just count by fives, that's 1 second, by fives of big blocks, and then that's 1 second. Are you with me so far?
Yes.
Okay. So let's go with, because the first step in analyzing a strip is to count the heart rate. All right, so let's begin with the first method. Let me just emphasize that when we do our calculation of a heart rate, these are all estimates, meaning these will not be precise, okay? The reason is we will only count using a 6-second strip. Now, why 6 seconds? Well, it's a nice round number because if you count the heart rate over 6 seconds, you just simply multiply that by 10 and then you get an approximate heart rate over 1 minute. The reason is it's impractical to do a full minute strip. First of all, you'll waste a lot of paper. Second, there's no room at any workstation. So you have a cow, which is only 1.5 feet long, wide, and then you have, even if you go to the table, let's say you shoo away all your coworkers, you'd like to use the entire nurse's station, it will still not be enough because you're talking about a 60-second strip here. So this is the actual length of 6 seconds. So multiply this by 10, you need 10 of these. That's pretty long, right? And then that would involve a lot of time counting it, and pretty soon it gets old, you give up, right? So 6 seconds is enough. So whatever you get, you multiply by 10, and that's your estimated heart rate. So the first method is, since we know that the PQRST is 1 cardiac cycle and therefore is 1 heartbeat. So the simplest way to do it is to, it only works it works best if your rhythm is regular. By regular rhythm, I mean how are the waves and complexes occurring? Are they occurring at about the same time, approximately the same time, or are they different? To do that, we actually need a caliper, but calipers cost anywhere between $4 to $20, depending on the brand you buy. So let's use a poor man's caliper. Everybody has a piece of paper, right? So go ahead and get a blank piece of paper, please. And it has to be white and no markings on it. That's the best thing. So everybody get a piece of paper and then push it up against your book or your computer screen. So let's use this sample right here. So let's measure the distance between this R wave and this R wave. So R wave number 2, R wave number 3. Are you ready? So put markers on your paper up here, and then put another marker over this R wave here. So R wave number 2, R wave number 3. You got it? Let me know when you finish.
Got it.
All right. Okay, so now move that piece of paper this time between R waves number 3 and R number 4. Is it approximately the same distance?
Yes.
Yeah.
Do the same for R number 4 and R number 5 and so on. Just move it along. Are they approximately the same distance?
My mommy taking my pen. Oh.
Yes?
Yes.
Okay.
Yeah.
So therefore, we can say that the rhythm, rhythm, but when I say rhythm here, I'm referring to the occurrence of each beat. Okay, are they regularly regular, or are they regularly irregular, or are they regularly irregular, or are they irregularly regular? If that makes sense. All right, so this method will work best on this type of rhythm. So if it's regular, we'll use this method. We will count, literally count, how many QRSs are there between this 3-second marker and this 3-second marker, okay? Because this is 6 seconds, so let's count. In order for a PQRST to count, all the PQRSTs must be within those 3-second markers. So is this PQRST here, this one, within this marker?
Yes.
Are they completely within that marker? The P, the QRS, and the T?
No.
No.
No. This P here is outside. This marker is here. So therefore this P, this is only half of a heartbeat, therefore. So we shouldn't count this. However, if you look at the other end of your 3-second marker, there is plenty of space here. So between this T, which ends here, and this marker here, can you move it to the right? Can you move it? So that we can move this one?
Yes.
Yes, we can. So let's see if there's enough room. So between, from this T to the end of the marker, there's about I see about maybe 3.5 small blocks, okay, between the end of this T and the end of this 3-second marker. So let's see where this one started. So this is approximately about 3.5 small blocks also from this 3-second marker. So this is perfect. So I can just move the whole thing. That way I can count this guy right here. Does that make sense? So now that I have it within this 3-second marker, can I count this guy now?
Yes.
Yes, I can now count it. So I count 1, 2, 3, 4, 5, 6, 7, 8, 9 times 10. So the estimated heart rate here is 90. For exam purposes, because I have no idea what method you guys will be using, because there are 3 suggested by your textbook. Therefore, there will be minor differences. So the question will be, the answer choices will be arranged. So I'll give you A, 60 to 70, B, 70 to 80, C, 80 to 90, etc. Any question? Because one question on the test will be asking you to count the heart rate. Any question on this method?
No.
All right, so that's just one method. There are 2 other methods. We'll just go down the chapter. Here we're back to the representation of your P, Q, R, S, T, and these are the explanations, what they are. So P wave again is just this one, okay, just the P is atrial depolarization or atrial contraction. We will disregard the PR segment, that's not really significant. So let's go now to the PR interval. So the PR interval includes the P and ends before the Q begins. Now, the question on most people's minds will be, why the hell is this called the PR interval when the R is right here? And it's only measured between the P to the beginning of the Q. I don't know how to answer that question. I had the same question too when I went to school. Why is it called the PR interval? Why not at least not PQ, not PR? PR is over here. Anyway, I never got answers. That's just how they call it. So fine, PR interval. So PR interval, again, is the time required for the atrial depolarization as the impulse travels from the SA node, meaning the SA node fired right here, and the impulse reached the AV node, but then the impulse reached the AV node instantaneously, right? But as you can see, QRS, which is now QRS is now the ventricular depolarization or ventricular contraction. How come this occurred here and not over here? Because it didn't take long for that lightning, for that electrical impulse to be released or generated by the SA node to reach the right? It shouldn't take a long time. It should reach it right away. That's how fast electrical currents travel. However, it did not. So there was a time here. So this whole time delay, measuring from the P to the beginning of the Q, is that delay. The electrical impulse was never transmitted by the AV node. It reached the AV node. However, the AV node did not transmit the impulse down to the ventricles, to the left and right bundle fibers. And this delay again allows the ventricles to fill with blood. After the atria contracts right here, the blood gets to the ventricles, and now the ventricles finally contract or depolarize, represented by your QRS complex. So you can see the amount of electrical activity there are in both ventricles during during ventricular contraction, considerably higher than the electrical activity happening in the atria. So you can see how strong the resulting contractions are by the ventricles. The ST segment, you can disregard the J point. The J point later will be significant when we go back to chapter 38 for the ECG changes in an MI. But even then, you don't really need to see the J point. I mean, you don't have to know that. So again, the P wave is important, the PR interval, the QRS complex, and then now the ST and the T. Okay, those are the only, is that 5? 1, 2, 3, 4, 5. Yeah, we'll only be testing the 5 complexes. The P wave, PR interval, the QRS complex, the ST segment, this isoelectric line right here, and then the T wave. So T wave, ST segment first. This is early ventricular repolarization. As I drew earlier, the cells here are becoming more and more, or at least they're beginning to get more positively charged. But as you can see, this is isoelectric, meaning there's none, if any, electrical activity in the ventricles. So therefore, this tells you that the ventricles are resting at this point, only a very short time. Okay, that's probably 0.1 seconds if you think about it, or even less. Okay, so this is the only rest that your ventricles have before it starts to polarize again. However, there's no contraction here. This is the contraction right here. So you can see that even if they're not contracting, they are actually still having a lot of electrical activity in there. You can also disregard the wave because you hardly see these. Sometimes they appear, most of the time they don't. Plus tells you here, it's really late ventricular repolarization, but I'm telling you, you never, well, maybe, yeah, every now and then you'll see a U wave, but not typically. Usually they show up if you have electrical imbalances, but again, very, very seldom do you see a U wave. The explanations are here. Please read them on your own, but only the waves and complex that I mentioned. So here we are again with the steps. We will not be doing the entire, because I think your book has 8 steps. Yeah, it has 8 steps. We'll only be doing 5. Okay. First is the heart rate. So that was one method of determining the heart rate, to count the number of QRS complexes within a 6-second strip. You can either count the P's, the R's, the T's, whichever one you want, or count the whole QRST, I don't care, but you count on heartbeat, okay? Just make sure that those PQRSTs are within your 6-second strip. And it's pretty simple. So if it's below 60, then your rate is automatically bradycardia. And if it's over 100, so starting 101, that is already tachycardia. The rhythm is what you just did with your paper. So that is the rhythm that is mentioned here. Okay, so step number 2 is using your poor man's caliper, piece of paper that you did, that is determining the rhythm. So you can either analyze the rhythm of the R's, or from P to P, from T to T, or R to R, which is usually what we use. That's determining the rhythm. Next is the P waves. First question to ask is, are there P waves in this patient's cardiac strip? Do we see P waves? All right, if you see one, do they look normal? Do they look the same from one P wave to the next? If they do, yes, that's great. So if there are no P waves, then definitely that's not sinus rhythm. A normal rhythm is called normal sinus rhythm, or just simply sinus rhythm. So P waves are present, then that most likely is a sinus rhythm. Okay, whether it's normal, not all the time, but P waves already indicate it's sinus, because that means where did the impulse come from?
Professor, quick question.
The SA no.
The SA no, very good. Yes, go ahead, Ms. Lam.
I have a question. PQRST has to come in between 6 boxes. So that 6 boxes is 1 second, right?
You
So,
mean
yeah, the small 6 boxes, that comes to be like 1 second. So if it's like 6 into 18, 3 of them is like 3 seconds. So one PQRST whole cardiac cycle has to happen in 1 second. So that means...
No, not necessarily. Okay, let's go back here. What is your question again? So
you said that PQRST has to be within 6 boxes, right? So like in 3 seconds, there's like 18 boxes, like 555, like
Well, it's
50.
not about that. You're just measuring the heart rate. I mean, there's no rule that your PQRST has to be within so many, because let's say that we get a 100 heart rate, right? Do you think they will be spaced like this instead of 90? Will they be, let's say we make this into 100, will the strip look like this? Will there be much difference between two R's? If this is, if we put 10, I mean, at least 6 times 10, 90. So if we add one more PQRST here, which will now make it 100, will they still be, how many are between this one, for instance? So this R number 3 and R number 4. How many big blocks are there? 1, 2, 3, and 3.4, right? So you think there'll still be 3.4 big blocks if we add one more heartbeat in this strip?
Maybe more. Maybe it will be more. It is like 100, right?
Did you say there'll be less or there'll be more big blocks between these two R waves if there was one more heartbeat here?
Oh, then it will be less.
Okay, so so again, what is your question?
My question is like, if we have to count the heart rate, so like PQRST, that's one cardiac circle. So that has to happen in 3 seconds. If it's a normal heart rate, so it could be like only 3 of PQRST, or it could be more. Because the more you have it, the more chances the heart rate will be more, right?
Yeah, of course. If you have 100 heartbeat bit or versus 60,
Mm-hmm.
if it's 60, there you only be seeing
Only one PQRST per second.
yeah,
If it's 60, then we can see only 60 heartbeat in 60 seconds.
right.
But if the heart rate of a person is more than 60, like it's like 90 or maybe 80 or something, then that PQRST has to be more than 60, right?
Yeah, of course.
Oh, okay. All right. Thank you.
But I don't see the significance of the question.
No, my question is like, I'm trying to find out how many the boxes would be for one PQRST.
I will
So
get to that shortly. Okay, you're a little bit ahead. All right, so we did the rhythm, we counted the heart rate, we analyzed the P. Okay, next is the PR interval. So this is the first measurement you have to memorize. A PR interval must be between 0.12 to 0.2 seconds. Therefore, if your heart rate increases, then therefore you can just imagine what will happen to your PR interval the higher your heart rate is.
shorter.
Very good, it's shorter. The lower your heart rate, what happens to the PR interval?
It will be longer.
It'll be longer. Does that make sense?
Yes.
And then the second number you're memorizing is the QRS duration. It should only be between 0.4 to 0.1 second. So that's about 1 small block to 2.5 small blocks, right? That should only be the QRS duration. Then the ST segment, it should be isoelectric, should be flat. As we discussed last week, if there is ST elevation, what does that indicate? That's a STEMI, right? ST elevation MI could also be present in pericarditis and hyperkalemia. What about ST depression? ST depression is non-STEMI. It should also be present in MI, but this is of course non-ST elevation MI, so that's N-STEMI. And the opposite, it will be instead of hypokalemia. So on the test question now, this will now go back to electrolytes. So I'll give you patient's labs. What do you expect to see? So therefore, when you have hyperkalemia, patient will show ST elevation. Hypokalemia, there will be ST depression. Okay, and as the T wave should be positive deflection. It should be going up. If it's inversion, what is the significance of an inverted T wave? Hello? What did you remember in chapter 38? T wave inversion. Hello? Can you hear me?
Yeah, Professor, we hear you. Can you just repeat that one more time, please?
T wave inversion, what's the significance?
It could mean myocardial ischemia.
Ischemia and potential and calcium imbalance.
All right, that was also present in STEMI, right?
Yeah.
All right, who came in late? Okay, I'll figure it out. All right, before we can see dysrhythmias, we have to see what a normal sinus rhythm looks like. So this is a normal sinus rhythm. So let's look at the steps we did. The heart rate. So a normal sinus rhythm, the heart rate must be between 60 to 100. So let's count this one. Let's use the only method we learned so far, which is counting the PQRSTs, right? Or counting the P's, counting the R's, or counting the T's. Okay. So these are our 3-second markers. So between this one and this one, how many PQRSTs are in there? So let's count. 1, 2, 3, 4, 5, 6, 7, 8.
9.
We count this one.
Yeah. 9, 10.
No.
You don't count, right?
Remember again, is how much distance do we have from this P wave here, which appears to be on small block number 4 from this 3-second marker. Let's look at the distance for this T right here.
And there's not enough to count it, not enough space.
That's too much. This would be 8. Did we count 8? 1, 2, 3. Yeah, okay, we have 8. So this heart rate is in the 80s. It's not exactly 80 because as you can see, there's still time here. So this will be 80 something. Okay, when you multiply this by 10. All right, so the answer, if I use this one on the test, the answer would be between 80 to 90. Does that make sense?
Yes, Professor, I have a question. What method did you just use to determine if you can count that extra R wave, I believe?
This one?
Yes, how do you know if you can count it within that 3-second span?
My first 3-second marker is right here.
Mm-hmm.
Because I can literally start counting here, but this P wave started over here.
Mm-hmm.
Small blocks after this one. So if I move this one here, so for me to begin here, is there enough space here? If I move this also 4 small blocks, will this be able to enter the 6-second marker, the 3-second marker? The answer is no, right? So
Okay.
therefore, I cannot count. Yeah, I cannot count this one. Unlike the example we used earlier, here, in this P wave here is about 3.5 small blocks. This one, we have 3.5 small blocks here between this T to the end of this 3-second marker here. So technically I can still move this guy all the way here. That means this one will also move here. And now that will now put this P wave within this, inside this 3-second marker. Did that make sense?
Yes.
So these are the characteristics of a normal sinus rhythm. The heart rate is 60 to 100. The rhythm is regular. So if you do your trusty blank paper caliper again, if you measure from this R wave to this R wave and then move those markers to this one, chances are it's going to be the same, approximately the same. And are there P waves? Yes, the P waves are here. They all look the same. They look normal. Is the PR interval between 3 to 5 small blocks? So this is my P and this is my beginning of my Q here. So yeah, just eyeballing it, yeah, it didn't go beyond 1 big block. Okay, so it's between 3 and 5 small blocks. My QRS duration, is my QRS between 0.4 to 0.1 seconds? Yes, it's between 1 and 2.5 small blocks. So it is normal. All characteristics are met. This is a normal sinus rhythm. Any question? All right. So let's now go to common dysrhythmias. So again, for the exam, all the strips that are found only in your textbook, as well as the one I'm giving you for heart blocks, are testable. All right. I'm not going to throw unusual strips at you or strips that are similar but not found in your textbook. No, to be fair, I will only, because you only have one reference, I will only use what's on your textbook. There are, I believe, about 9 strips here. So we have 1, 2, 3. 4. I mean, you can count, right? There should be about 9 there, 5, 6, 7, 8, 9. Yeah, that's it. It's about 9 strips here. So easiest test you've ever taken.
Professor, I have a question.
Go ahead.
You see how your example for the QRS is between 1 block and 2.5 blocks? For the PR, would it be between 3 and 5 blocks?
Yeah, 0.12 to 0.2. What did I say?
Okay, I'm just making sure.
Okay. All right, so we have no picture of a PAC. Therefore, I cannot test it, but I can describe it though, because there are descriptions here on the paragraph. So a PAC would be a P wave that occurs out of rhythm. Let me show you an example. Just imagine, okay? So let's say this is a sinus rhythm. So if you use your trusted blank paper caliper, if you measure from this P wave to this P wave, have you done that? So let's say this P wave to this P wave, I count about 1, 2, 3, 3, and 1, 2, 3, 3.5 big blocks, right? So between this P wave, because this is where this P wave begins, so this is about half of a big block. There's 1, 2, 3, 3 big blocks and a half, 3.5 big blocks between this and this. And then if I count from this one to this P wave, This is again 1, 2, 3, about 3.5, maybe 3.4, right? Very small difference. This is still regular rhythm. A PAC would occur sooner. So let's say if this is a PAC and it's supposed to occur 1, 2, 3 right here. If this occurs right here, maybe, meaning it occurs sooner, then it's a premature atrial contraction. Meaning it's not supposed to occur at that time because the pattern here is supposed to be every 3.5 big blocks, then there's a P. So let's say this one, 1, 2, 3, there's the P, and then 1, 2, 3.5, there's the P, and so on. It's supposed to occur in that interval. However, if your P wave occurs sooner than that, instead of 3.5 big blocks, it occurs right around maybe 2.5 big blocks, or at 2 big blocks later. That's a PAC. It's very easy to see also because what will follow a PAC is a pause. Great. So this is an example. Okay, you see this picture here? So here, there's an underlying rhythm here. So between this, and this, they have the same distance. But look at what happens to this one and this one. So this P wave right here is called a PAC. This one is also called PAC. But what do you see right after it happens? You see a pause. It always follows it. It'll also be the same when we talk about a premature ventricular contraction. There seems to be a pause right after it. It's not a long pause, but it's a very noticeable. Okay, you'll see a pattern. How come there's a pause here? Okay, so here another pause. That means that beat occurred prematurely. It always happens after a premature beat. So there will be a short pause like this one, for instance. These are PACs, and followed by a pause right here. Here's another example. Okay, that's a PAC, and then there's a pause there, another PAC, pause, and then you have your underlying rhythm. PACs, therefore, are, as stated here, are they serious? Do you worry about a PAC?
Yeah, it shows that the heart rate is beating faster.
It can, and then the patient will also feel as them skipping a beat because during the pause, yeah, it did literally skip a beat. But the significance here is if the patient has a cardiac history, so yes, we will monitor the patient, meaning it's concerning if a patient has a cardiac history. But healthy people like you guys will just probably look at the causes. This one here, for instance, a PAC, what are the known causes of PACs? There's none here. Anyway, so a PAC usually is caused by coffee. If you guys are coffee drinkers there, you may have PACs or even PVCs, right? That's usually the cause. But is as long as you don't have no cardiac history, our advice for the patient is just, did you just go smoking or did you just go have a cup of coffee? And if they say yes, oh yeah, okay, so that would explain the PAC. Okay, and then all we'll advise them to do is just cut down on it, or if you could stop smoking, stop coffee, then that'll be great. All right.
Professor, do people who are regular coffee drinkers, do they still have these dysrhythmias, or does the body adjust?
Say again.
People who drink coffee regularly, do they normally have these dysrhythmias all the time, or does the body get used to it and then they don't have it anymore.
Yeah, I don't think it happens that you get used to it. No, it always gets better if you stop the practice. If you stop the habit, always works better. Let me
Okay.
just show you what a bigeminies and trigemini, quadgemini looks like. Okay, these are PVCs. So these are your regular QRSs. This one is distorted, looks abnormal. That is a PVC. Here you have normals again and then followed by another. So that is a PVC. Now the pattern will make a difference. So we call it, so this one, these are the same, right? So that means they're unifocal, because meaning that means only one source is causing this. One rogue cell in the ventricles is causing it. This one, there are two different rogue cells here, because this one is a different looking PVC. This one is also a different looking PVC, but they're both distorted, but they don't look the same. That means this is called a multifocal, because you have more than one source. It's not caused by the same source because they look different. Now, if the pattern is, let's say every other, so this one normal, PVC, normal PVC. So the pattern indicates that this is bigeminy, meaning it occurs every other heartbeat. It becomes trigeminy if you have it every 3 beats. 1, 2 PVC, 1, 2 PVC, 1, 2 PVC. That's a trigeminy. Then of course we'll have, if it occurs every 4th heartbeat, then that's called a quadrigeminy. If it occurs 2 at a time, this one 2 in a row, that's called a couplet or a twin, couplet. And then if it's 3 in a row, then that's a triplet. Right, so that's what bigeminy, trigeminy, quadrigeminies mean. Now for signs and symptoms, this will be the easiest question to ask, because regardless of the dysrhythmia, have you ever seen a dysrhythmia or heard of a dysrhythmia that will increase cardiac output? Is there such a thing?
No.
No. Every abnormal heart rhythm always drops your cardiac output. It always causes low perfusion, because you have a beat that is out of rhythm. Of course, that will cause congestion in one or more chambers, and therefore will disrupt the unidirectional flow of traffic or unidirectional flow of blood in and out of the heart. So therefore, all dysrhythmias will affect cardiac output. It's all of these, though the severity will differ. Of course, if you have only sinus brady or sinus tachycardia, as long as it's sinus, yeah, they are dysrhythmias, but they typically won't cause any significant decrease in cardiac output. So again, all dysrhythmias will cause low cardiac output, so therefore will share the same symptoms. It's just a matter of what is the severity, because that will make a difference now from one dysrhythmia to another. Some dysrhythmias cause more significant cardiac output drops compared to others. So if you look at Brady dysrhythmias, for instance, are Brady dysrhythmias always bad if your heart rate is less than 60? Does it say so in these 3 bullets here? Is it bad?
I don't think we can see what you're seeing right now.
Oh, sorry. Okay, I'm on back to your textbook. So look under Brady dysrhythmias. Are they bad?
Not necessarily.
No.
Necessarily. It really depends on, well, how bad is the decrease in heart rate. If it's in the 50s, with especially with athletes like me, for instance, you know, athletic guys, ripped guys like me, we have a low heart rate. Okay, so that means our heart is so strong that we don't require 60 beats in order to perfuse our body. Okay, so if you know become ripped like myself, for instance, you know, like the six pack I have. So if you're well trained, your heart rate will drop. Okay, I'm trying to encourage you to be more like me. Michael is almost there.
I'm working on it, Professor.
Now,
After the NCLEX.
why are you laughing?
The professor's making joke. Oh, six pack.
I haven't finalized the exam yet. I can still change it. All right, tachydysrhythmia. So any heart rate, any dysrhythmia that results in a high heart rate, except again sinus tach. Sinus tach typically won't cause any change in the heart rate. I mean cardiac output, unless it becomes sustained, like it's your heart rate's 110 for several days now. So yeah, of course the heart rate will cause a drop in your collectively, you know, over time, yes. But as long as it occurs in spurts, let's say when during exercise, for instance, it doesn't cause any change in the cardiac output. Or our concern really here is a drop in the cardiac output. But just take note that as you told me earlier that higher the heart rate, remember that the PR interval narrows. It shortens the PR interval. Therefore, it will affect cardiac output. So the higher the heart rate, the narrower the PR interval, the shorter the ventricular filling, the lesser the cardiac output. So therefore, all tachydysrhythmic patients will share the same symptoms. But if you compare that to the bradydysrhythmias, of course, although not all will show symptoms, but definitely if the heart rate is low enough, though, they will share the same signs and symptoms. Because once cardiac output drops, then of course this will show up. Patient has, well, maybe with the exception of palpitations. So if you have a bradycardia, heart blocks, for instance, your patient won't feel any palpitations because the heart rate is the opposite. Instead of very fast, it's very slow. But all of them though will have chest pain, pale blue skin, all symptoms of decreased cardiac output. So as you can see here, they share the same key features. So all of them, whether the heart rate's high or low, they have these common symptoms of low cardiac output. If you look at them, they result in congestion of blood in the lungs because the heart pretty much isn't emptying, right? Because the heart now, the blood is now stuck in the heart. Okay, if your heart rate's really too fast or too slow, resulting in crackles. So pretty much the patient is in heart failure here. So less perfusion, you have nausea, vomiting, there's decreased urine output, hypotension, and jugular vein distension. Now, as you read these here, as we begin with dysrhythmias, answer four different questions for each type. So beginning with sinus dysrhythmias to atrial to ventricular dysrhythmias, you always start with what does it look like? Not all of them have strips on your textbook, so you don't have to worry about that. But if there are, yes, you should recognize what the dysrhythmia looks like. Next question is, what causes it? What are the causes of this type of dysrhythmia? What are they associated with? Signs and symptoms you already saw right here. Chart 34-1, these are the signs and symptoms of these dysrhythmias. They share them. So the next question is, what do you do about it? Now, as far as interventions go, you'll quickly find out that not all of them are necessarily treated. There are minor dysrhythmias which do not require pharmacologic interventions. Some of them can be eliminated by simply eliminating the cause. Very common causes is coffee, smoking, medications, okay? Or sensations, for instance, like pain or fever. These are going to cause dysrhythmias as well, right? And then finally, the number 4 is your patient teaching. What do you teach the patient? Patient will be taught either regarding the dysrhythmia, how to identify symptoms and all that, or regarding their treatment. Okay, what do they do if they take this medication, for instance? Okay, so 4 questions again. What does it look like? What causes it? Signs and symptoms is a given, so no need for that. Next is the intervention. What do you do if you see this dysrhythmia? Now, as far as the interventions, there are steps for certain dysrhythmias dictated by your textbook. So your textbook tells you, of course, they grab this all from the American Heart Association website or recommendations. What do you do first when you see this? And then as far as medications go, what are your nursing responsibilities when giving them? And what are your patient teaching regarding the dysrhythmia, the causes, and the treatment? All right. We'll do this last chart and then we'll go on a break. Chart 34-2 is for all dysrhythmias. These are common interventions for any patient who has a dysrhythmia. So you learned in respiratory that who do you assess first, the ventilator or the patient?
Patient.
All right, same thing here for dysrhythmias. Regardless of what the cardiac monitor says, when you run to your patient's room, look at your patient first. Okay, assess your patient and then look at the monitor next. So you always, with every dysrhythmia patient, check vital signs often, at least every 4, so more often is better. Monitor them for dysrhythmias. One thing about dysrhythmias is once one starts, it could be a warning for another, which is way worse than what you're looking at. So they usually get worse, okay, if you don't do anything. This is why you monitor the patient first, is each patient responds differently to a dysrhythmia. I've seen patients who are wide awake with a heart rate of 32 and somebody who was already passed out at a heart rate of 55. So people treat dysrhythmias differently. Same thing for blood sugars also. I've also seen hypoglycemic patients with a sugar of 20 still talking to me. And then somebody who had a 60 who was already unconscious. Chest pain is expected because that's decreased cardiac output. So of course, remember that the heart perfuses during diastole. Then if there's chest pain, then you already know how to manage chest pain in chapter 38. Peripheral circulation here is done to check for peripheral circulation. So between central and peripheral circulation, just check if is there enough blood getting to the distal organs or distal parts of the patient's body. So pulses is number 1 here, along with your cap refill and the color. If indicated, then give medication, and then of course you follow your drug book, know what does it say, and procedures like this one, these 2, we'll explain the difference between the 2 later, and patient's response to those medications. One thing to remember with this antidysrhythmic agents is once you get to the chart where all these medications are listed, you quickly see that on the last column, the side effects are other dysrhythmias, meaning you give one antidysrhythmic today, another dysrhythmia may result because of that same medication. We call that pro-dysrhythmia. It makes sense because, of course, these drugs in order for them to work, that means they have to interrupt the normal conduction pathway of the patient. So therefore, that has a high potential to cause another dysrhythmia because of their very action, because they either increase or decrease the conduction pathway or the opening and closing of the calcium channels, for instance, then of course that will result, could potentially result in another dysrhythmia. Lab values are related to both the medications or from the cause of the dysrhythmia, because you learned last week that acute coronary syndromes can result in dysrhythmias. Activity tolerance is of course directly related to the cardiac output. So if they're unable to tolerate activity, that means there's not enough cardiac output. Cardiopulmonary functions are related, so check for pulmonary symptoms. Stress, of course, increases cardiac workload, and we already concluded that all dysrhythmias will affect cardiac output and perfusion. So try to reduce stress. And of course, offer support. All right, we'll begin here after the break. Come back at 15 after 2.
Okay, Professor, thank you.